Good morning, guys. My name is Eric. I'm one of the attendings across the street at Kings County, former grad from this program. I'm going to be going over basically monomorphic VTAC, most particularly the ECG features of VTAC. So we're going to start with the EKG. Normally this would be interactive, so it's kind of a little bit weird because everyone's attending the crowd. But what's your first impression of this EKG?
Where is that patient?
So we're assuming this patient is stable enough to get a 12-lead EKG, but is this fast or slow?
Fast.
It's fast. Is it wide or narrow?
Wide.
Wide. And is it regular or irregular?
Regular.
So what's on your differential diagnosis?
You can ask the folks at home to pipe in too. Anyone at home? Anybody out there?
So Stephanie said VTAC.
VTAC.
Okay.
Anything else?
SVT with aberrancy.
Yeah, SVT with aberrancy. Can anyone think of anything else?
SVT with an underlying bundle branch.
Yeah. There's also antidromic ABRT, which is seen in people with WPW. And think about tox and sodium channel blockade. This lecture will focus mostly in differentiating VTAC from SVT with aberrancy. And for those who don't know, SVT with aberrancy is basically an SVT with a bundle branch block pattern. This can be a kind of SVT-driven bundle branch block where you see only at high rates due to differences in refractoriness of left and right bundles. Or you can see it in someone who already has a pre-existing left bundle branch or right bundle branch block. So let's go on to the next EKG. So what's your kind of impression of this EKG? Is it sinus? No, so there are no P waves. Is this narrow or wide?
Wide.
It's wide. If you're looking, I think maybe like V1 or V3, the widest you see the QRS is about 160 milliseconds. Is this regular or irregular?
Regular.
It's pretty regular. So what's kind of on your differential diagnosis? I heard SVT.
SVT with a bundle.
Yeah, so SVT with right bundle. What else could it be?
WP.
SVT with aberrancy. Could it be VTAC?
Could be.
It could be, yeah. And is there like any particular features? Is there any way where you could be be confident that it's an SVT or a VTAC? Sorry.
AVR.
AVR? Yes. So Sophia mentioned AVR, but we'll talk about that later. So there's an easy way you can tell is you can actually look in the patient's chart. So here we're going to Muse, an Epic, and we discover the patient has 3 different EKGs you can look for. So you're very relieved, and you click on the first one. This is what you get. So you go back and you click again, get this again, but third time's a charm, right? So you finally you hope there's an EKG available, and you get this. So now where do we go from? You're stuck with this YQRS complex, patient's tachycardic, and you want to say it's SVT, but VTAC is a lot scarier, and VTAC's still different. So in the next 10 minutes, I'm going to go over some other ECG features, distinguishing VTAC from SVT. So you can actually, there's parts of the HPI which actually kind of increase the likelihood that you're dealing with VTAC when approaching a wide complex tachycardia. These include prior MIs, active MI, prior history of VTAC, age over 35, any family history of sudden cardiac death, or the history of any CHF or cardiomyopathy. But the the thing we think about the most is kind of the QRS width. As the QRS gets wider, it becomes more specific for ventricular tachycardia. But it's kind of interesting that, it's not, even at widths of over 140 milliseconds, it's not that sensitive, 76%. So there are ventricular tachycardias that are between 120 and 140, which can appear narrow on the EKG. Another feature of VTAC is Precordial Concordance. So what concordance means is that you look at the V1 through V6, and most of the having concordance means you have either mostly R waves or S waves, and these are monophasic. And when you have positive concordance, it means you have all R waves. And if you have negative concordance, this means you're looking at mostly S waves in the precordial leads. And this is very specific, but it's not that common. It's only 70 to 21% sensitive. And you can also kind of see this in antidromic ABRT. You can also see AV dissociation in VTAC. This refers to when the P and QRS complexes occur at different rates. It's kind of a reflection of complete lack of communication between the atria and the ventricle. And why does this happen in VTAC? It's because basically the AV node is getting a barrage of ventricular impulses from the kind of reentry circuit, and it shuts down the AV node and puts it into a state of refractoriness. And the AV node still works, but it's essentially turned off. And this finding on EKG, although it's very hard, especially on the short, 10-second strip, is the most powerful predictor of VTAC. Kind of an indirect way of looking for AV dissociation is looking for capture and fusion beats. So occasionally, supraventricular impulse will reach the AV node. At the right millisecond, it's no longer in refractory state. This impulse can capture the ventricle or cause a fusion complex. Capture beat occurs when the impulse hits the right sweet spot and triggers normal conduction. This QRS complex will look similar to the patient's native rhythm, whereas a fusion beat occurs when the polarization of the ventricles occurs from two organs. So one being the supraventricular impulse, typically from the atria, and one from the ventricular focus, which is causing the VTAC. And this will cause a unique complex from these fused vectors, and this will not look like the patient's native beat. And so to kind of summarize the classic EKG findings in VTAC, you have wide QRS, Precordial concordance, AV dissociation, capture, fusion beats. And the latter three are basically pathognomonic, but they have very low sensitivity. So just because you look at an EKG, they don't have these findings, doesn't mean you've ruled out VTAC, but you can rule them in. So there are many algorithms that have been kind of proposed over the years that stated that they've been having the problems like 99% sensitivity, 99% specificity, but they've all fallen short in terms of external validation. But I'm not going to go really into detail of the actual algorithms themselves, but they do provide some additional ECG findings that may be helpful in distinguishing VTAC from SVT. So one of them being extreme axis. So you can look at one in AVF. If they're both down, this is actually pretty rare in supraventricular tachyarrhythmias. So if you have an EKG with extreme axis, and they point to VTAC. A very specific and somewhat sensitive finding in VTAC is also a dominant initial R wave in AVR. This has been, I think, proposed kind of in 2007 the Varecki method, and it's been kind of seen in subsequent studies as well. So it's kind of held up. Another finding, which was first described by Brugada in 1991, is having no RS waves in V1 through V6. This is kind of like concordance, but you can have mixes of S and R waves. And it's pretty specific, but also not very sensitive. So another finding in VTAC that's somewhat specific is actually measuring the onset of the R wave to the nadir of the S wave. And if it's more than 100 milliseconds, it may be indicative of VTAC. And this is kind of representative of the slow cell-to-cell depolarization you see in VTAC. Whereas in a SVT, you're starting with the fast conducting fiber, so maybe you'll have a faster interval. Another measurement is the R wave to peak time, which is also described by Brugada and proposed in 2010. It's basically you measure the onset of the R wave to the peak of the R wave, and if it's more than 50 milliseconds in lead 2, it's somewhat specific for VTAC. Initially, it was proposed to be 99% specific, but subsequent studies have shown it to be less sensitive and less specific. And here are just some examples of calculating the R wave to peak time interval. So kind of to summarize these advanced EKG findings, you look for extreme access. You can measure the R wave to S nadir interval in precordial leads. And if any one of them is greater than 100 milliseconds, it may be VTAC. You can measure the R wave peak time. And if you can also look at the precordial leads, if they may not have concordance, but if they have no RS waves, and they're just R waves or predominantly S waves, that may also be another sign of VTAC. And the most, I guess, sensitive and specific finding among these is initial R wave and AVR. And I've kind of divided them into 2 different categories, findings that likely point to VTAC and findings that possibly point to VTAC. To summarize again, likely findings would be AV dissociation, precordial concordance, no precordial RS waves, capture fusion beats, and initial R wave and AVR. And some findings that may point to you but not be totally specific for VTAC are having a wide QRS complex greater than 160 milliseconds, extreme access, an RS nadir interval, and the precordial leads greater than 100 milliseconds, and R wave to peak time is greater than 50 milliseconds. All right. So there's another method. So if you're looking at a wide complex tachycardia and it looks like a bundle branch plot, you can divide them into 2 different categories. One being you look if the EKG has classic bundle branch features, and it's proposed in a paper by Griffith. And if they do, you can conclude that's SVT with aberrancy. In that paper, the sensitivity and specificity was maybe in like 80-90% and hasn't been externally validated. Another way you can look are you look at the bundle branch plot and you look at V1, V2, and V6, and they have like kind of atypical features that aren't seen in the classic bundle branch plot. This may point to VTAC, and we'll go over that. So quickly, to go over regular conduction, you start with the SA node and travels down to the AV node, and which then travels down into the left bundle branch and the right bundle branch. And the left bundle branch splits into left anterior, posterior fascicular fascicles. There they'll spread through the Purkinje fibers into the subendocardium. In the right bundle branch block, you have the left bundle branch. You have the right bundle branch blocked, so the impulse goes down the left bundle branch. Once it hits the left ventricle, you'll have cell-to-cell depolarization to the right ventricle. So when you talk about right bundle branch like morphology, I'm referring to positive R waves in V1 and V2. So here's a normal sinus rhythm in right bundle branch block. What are some classic features of a normal right bundle branch block?
RSR prime.
So someone mentioned RSR prime. Anything else?
Bar rate,
So R prime greater than R in V1, Dr. Cinder mentioned. So the first one, V1, V2 often has an RSR prime, and the R prime is usually greater than the R. This means the right bunny ear is bigger than the left bunny ear. Also, what you can find is look in V1 and V6. For simplicity's sake, we'll just look at V6. And you can actually measure the R amplitude to S amplitude ratio, and usually that's greater than 1. So here you have 9 millimeters amplitude for R wave and 4 millimeters for the S wave, and 9 divided by 4 is greater. Here's just an example of an SVT with right bundle branch block. Here you can appreciate the triphasic RSR prime, and the right bunny ear is bigger than the left bunny ear. And in V6, you can see just by eyeballing that the R wave is bigger than the S wave. So you're likely dealing with an SVT with the right bundle branch. Just to summarize again, so typical features of right bundle branch block, which may point to an SVT, is a triphasic RSR prime, and where the R prime is greater than R, and then V6, the RS ratio is greater. So when you're in VTAC, there typically isn't a triphasic RSR prime wave in V1, V2, and instead you can find one of 3 findings. You can either have a monophasic R wave, which you see here, which is basically just one big wave without an S wave, or you can have kind of an R prime wave without the S. Typically, the R prime is smaller than the R, or in other words, the left bunny ear is bigger than the right. The third finding you may see is a QR wave, which you won't see in a typical right bundle branch block. In V6, instead of having this RS complex, you may either just have one large S wave, QS wave, or you can have an RS complex where the R wave is smaller than the S wave. So to summarize again, so in VTAC you have the monophasic R wave, or QR wave, or a left bunny ear bigger than the right bunny ear in V1, V2, or in V6 you have a RS ratio less than 1, or a large QS wave. To kind of simplify it, you can have either in the SVT you have a triphasic RSR prime, where the right rabbit ear is taller, and V6 you have an R dominant wave, and VTAC you have a left rabbit ear that's taller with an S dominant wave in V6. So here you have a VTAC with right bundle branch like morphology. You have kind of positive waves in V1 and V2, and if you look closely, they look either monophasic, or you can kind of tease out RR prime waves in V1, where R is larger than R prime. If you look at V6, the R wave looks a little bit smaller than the S wave, and then the ratio is less than 1. So next up is the left bundle branch morphology. Here you can see the left bundle branch is blocked, so the impulse goes down the right bundle branch, and then depolarization occurs from cell to cell, from right ventricle to left ventricle. And when I'm talking about left bundle branch morphology, I'm referring to a dominant S wave too. So here's a normal sinus rhythm with left bundle branch block. What are some kind of classic features of a normal left bundle branch block?
White press. Down.
So down V1, V2.
Left axis.
Left axis. Anything else? All right. So someone mentioned downward in V1 and V2 here. You actually can sometimes see very small R waves and a big S wave. And typically you have a very steep S wave, followed by a less steep kind of rise at the end of it. This kind of reflects the rapid depolarization along the bundle branch of Purkinje fibers, followed by the kind of cell-to-cell depolarization of the left ventricle. So this is typically, you can actually measure this from the onset of the S wave to the nadir. If it's less than 70 milliseconds, this may indicate left bundle branch conduction. conduction. So also in a left bundle branch block, you can have monophasic waves, R waves in 1 and V6. But at higher rates, it becomes a little bit less specific. All right, so here's an SVT with left bundle. Here you can appreciate the RS waves, and here the S wave looks pretty steep. It looks less than 1 box. The S wave onset to the nadir looks less, about 1 box, so about 40 milliseconds, so it's less than 70. And in V6, you can appreciate the monophasic R wave. Here, you actually don't see the monophasic R wave. Instead, you kind of see an S wave. Sometimes this can happen at fast rates, even if you have a left bundle branch block. It's because sometimes the impulse jumps from the RV to the LV, and it'll hop onto the left posterior fascicle, and they kind of mimic a left anterior fascicular block where you have S waves in V3, V4, V3 through V6. So just to summarize, in an SVT with left bundle branch morphology, you have either RS or QS waves in V1, V2 with its steep S wave or monophasic R waves. So onto a VTAC with left bundle branch morphology. Typically, instead in a VT with a left bundle branch block, you have actually a wide R wave instead of a small S wave. This R wave can be greater than 30 milliseconds. You may also see some notching of the S wave. You can appreciate that's very specific for VTAC, but not very sensitive. Here you can also appreciate R to S interval, R to S nadir interval greater than 70 milliseconds I mentioned before. In V6 in a VTAC, you instead of seeing a monophasic R wave, you might just see S waves or QS waves, or you may see a QR wave. So just to summarize again, in VTAC you may have initial R wave greater than 30 milliseconds in V1, V2, and then notched S wave. And in V6, instead of having a monophasic R, you may see a QS or QR wave instead. Here's a EKG of VTAC with left bundle branch like morphology. You can appreciate the kind of fat R wave, which is about 1 small box, which is about 40 milliseconds wide. And you can see the notched S waves here, which almost is diagnostic of VTAC. And here the R to S nadir interval is about 100 milliseconds, which is greater than 70. And in V6, it kind of looks like a monophasic R waves, which you would see in a normal left bundle branch block. If you look closely, you can see Q waves, which you shouldn't see in an SVT with left bundle branch block. So just to summarize all the findings I just discussed, and some features that are likely to point to VTAC, you may see AV dissociation, Precordial Concordance, no precordial RS waves, capture fusion beats, initial R in AVR, or an S wave notch in V1, V2. All these may point to VTAC rather than SVT with aberrancy. Some findings that are less specific include a wide QRS, extreme access, an RS wave in V1 through RS interval to the nadir V1 through V6 greater than 100 milliseconds. R wave peak time greater than 50 milliseconds in V2, or atypical bundle branch features which just discussed. And if you're looking at a wide complex tachycardia with typical bundle branch features, it may point to SVT. Some of you may be asking, does any of this even matter? Because when you're dealing with a wide complex tachycardia, they're unstable, you're going to shock whether they're going to be an SVT or VTAC or not. And in current ACLS protocol, if the patient is stable, you can try adenosine, regardless of what you think it is, just to see if it breaks the tachyarrhythmia. I'll leave it up to you to ever commit this to memory, but that's the end of my lecture.
Any questions? Yeah, Dr. T.
But you're right. To say, yeah, does it matter? Obviously, if they're unstable, like you said, you're going to synchronize cardiovert if they have no pulse, inflate. But if they're stable, if you think it's more likely, for me at least, I don't give adenosine to everybody, but if you think it's more likely to be an SVT with aberrancy or with a bundle, then I would try the adenosine. If you're really thinking this is VTAC, but they're stable, then I would try something else like amiodarone. So I think it makes a difference. Plus, it makes a difference, even if you break it, it makes a difference what you're going to give as your follow-up treatment, right? If you think that it's really VTAC, you're going to have them on an antiarrhythmic that treats VTAC, like amiodarone or procainamide or one of those others. Whereas if it's an SVT, you would have them on something else, like a beta blocker or a calcium channel blocker. So I think it makes a difference to be able to know. And I think that was a great lecture to go over things that let you know.
All right, thank you, Tang.